Hello, we are very happy you were able to join us for this training on the Home and Community-Based Settings Rule. My name is Erica Healy, Provider Oversight Specialist at the Ohio Department of Aging, and I am joined by Angela Baker, Provider Oversight Manager, and Heather Young, Provider Oversight Specialist. Today's presentation may be a refresher for some and new information for those of you new to the Passport and Assisted Living Waiver programs, so this will provide a good basis for your home and community-based settings foundational education. Today's training goals include, for new provider staff, become familiar with history, terminology, and concepts, introduction to the regulations, and understanding the importance of each review. And for our experienced staff, it's a refresher of the regulations and process, a way to share helpful hints and best practices, and to identify and problem solve weaknesses in the review. The settings rule came about as CMS assessed and determined individuals in our population were not receiving service in the way the waiver intended, which was in the community. The whole point of the waiver is to provide services to individuals in their homes so they may remain in their home in the community they choose and avoid institutionalization. As a result, the Home and Community-Based Settings Rule came about and was effective March 17th of 2014. Ohio developed their assessment plan and determined Ohio would have categories of providers. We will discuss more on categories in a few minutes. The next step was to visit every assisted living and adult day center in the system at the time. Some of you may have participated in the initial determinations. At the same time, Ohio was writing their transition plan, which told CMS how we would implement and oversee the assisted living and adult day settings once implementation was complete. The rules developed are in 5160-44 of the Ohio Administrative Code. Specifically, 5160-4401 applies to the provider and their setting. All through this process, Ohio has attended many meetings with CMS, the Administration on Community Living, and other states to understand and learn more about the expectations from CMS. You have probably noticed a lot of rule changes and emphasis getting away from the setting structure and more to the individual's experience. The settings rule, at the end of the day, is about individuals' experience at the setting they reside or attend. This slide contains all but one of the required components of the rule at a very high level for both adult day service and assisted living waiver providers. They are meaningful distinction, community integration, autonomy and choice, physical accessibility, privacy, transportation, access to food, and employment or volunteer opportunities. This slide represents Ohio's 4 home and community-based settings categories. The B and C categories apply to both adult day service and assisted living waiver providers. Category B is a setting which is in the community and is a freestanding building or resides on a continuing care retirement community style campus. Category C is one that is on one or more prongs. A setting in a publicly or privately operated facility that provides inpatient institutional treatment, a setting that is in a building on the grounds of or adjacent to a public institution, and a setting with the effect of isolating individuals receiving Medicaid home and community-based services from the broader community of individuals not receiving home and community-based services. An example of this prong: in the guidance issued in 2019 to state Medicaid directors, which replaced previous guidance around isolation, focused on the following traits. 1. Due to the design or model of service provision in the setting, individuals have limited, if any, opportunities for interaction in and with the broader community, including with individuals not receiving Medicaid-funded home and community-based services. 2, the setting restricts beneficiary choice to receive services or to engage in activities outside of the setting. Or 3, The setting is physically located separate and apart from the broader community and does not facilitate beneficiary opportunity to access the broader community and participate in community services consistent with the beneficiary's person-centered service plan. This does not mean we will no longer consider a provider in a Category C as presumed to be institutional. We still have to look at the settings with the lens towards heightened scrutiny because they are co-located with a nursing facility and have the potential to isolate individuals. The review is to ensure they continue to meet the functional criteria we just listed. An example of this type of setting is a setting that's in a community that is in the middle of nowhere, but all the other residents in the area are not isolated. If the individuals living in the assisted living setting do not have the same proximity to the community as individuals residing in private residences, then this prong is applicable. Another example is if all the individuals in the setting are of the same intellect or disability and their only interaction is amongst one another. No outside community interaction, no outside activities, no visitors, just the individuals and the staff. That is an example of the provider isolating individuals from the broader community. This environment does not have to be rural. This can happen in an urban setting as well, and it can happen in both Category B or Category C settings. The purpose of heightened scrutiny is to provide an opportunity for a presumptively institutional setting to continue receiving federal funds for the home and community-based services if the state and CMS affirm that the setting adheres to all regulatory settings criteria. Why are the home and community-based settings reviews important? The reviews are important to ensure that individuals on the assisted living waiver and passport have a choice in where they live, who they live with, and the other services independent from the assisted living. If someone isn't happy with the services they are receiving at the assisted living or adult day center, they are given the opportunity to speak to somebody regarding their choices. Privacy is the first topic we will review. Individuals residing at an assisted living are leasing an apartment and have the same rights to privacy that you and I have. They must be able to have private conversation, determine who has access to their personal possessions and apartment, have their information kept private, and personal care should be delivered privately, even if the individual is sharing a unit. They must be able to have privacy during all ADLs, even if they are receiving assistance. Some examples of best practices for privacy are listed on this slide. And some other examples might be not keeping individuals' charts out where someone could easily review, not posting individuals' meds or med times on a bulletin board, or having individuals line up near the nursing station to receive their meds. Just a note, you will notice this slide repeated with slight changes throughout the presentation. As we have learned, like you, providers keep information in different places. So we've listed all possible places you might find the information. On this slide, we have listed where you may find examples of the provider implementing privacy practices, as well as training for their staff regarding privacy. The most helpful for gaining insight into practices at the settings are the observations by the review teams who conduct the individual and staff interviews on site. The next tenet we will go over is treating individuals with dignity and respect. This treatment must occur at all times and in all aspects of the individual's life. Examples listed are respecting the individual's likes and dislikes. An example is hearing how a staff person will say they will try to coax an individual to participate in something they don't wish to for socialization. Individuals get to make decisions about their lives and the providers must respect this, even if the decision is a bad one. They should document and reach out to the guardian or family member or case manager depending on the situation. Another example is talking with them in a way they feel respected and are being heard. Provide services to the individual in a compassionate manner that preserves their dignity. On this slide, we have listed a few best practices. I also want to note this is an area CMS had a finding in our state at the settings they visited in May of 2022 for the on-site heightened scrutiny review. One example that sticks out is an aide telling the provider the individuals were her babies. These individuals have had lives and experiences before they ever came to the setting and should be treated with dignity and respect. Other examples we have listed is encouraging individuals to dress and style their hair the way they want to, not the way the guardian or the provider desires. Using their preferred name, not hun, sweetie, or some other iteration of the same. And ensuring staff are including individuals in the conversation rather than discussing them as if they are not there. These practices apply to both adult day service and assisted living. Again, we have listed documents we have found examples of dignity and respect being trained and/or observed in the setting. Next time you are conducting a review, observe how the aides are treating or talking to the individuals. Next, we will talk about no coercion or restraint. In the early days of home and community-based services, we had a provider leave our network because they stated they would not give up using chemical restraints. Our team found a provider who intimidated individuals to go to the dining room with bullying, and a provider who had put barriers across everyone's room to keep an individual with wandering tendencies out of everyone's apartment. But the unintended consequence was the other individuals residing there were restrained in their units. And we had an adult day center who insisted everyone had to participate in an activity regardless of their desire because it would help their memory. This seemed like a good idea to the provider, but we educated them, and the next time we went out, the barriers were gone. These are just a couple of examples of providers thinking they are doing the right thing, but it really goes against the home and community-based settings requirement. Some examples of best practices are training staff to recognize coercion and restraint. It is not always intentional, but still must be addressed. Posting a recipient rights document in a public area where individuals or guardians are likely to see it. Including the individual's rights as part of the lease or residency agreement or the adult day center agreement, and keep a record of giving individual rights to each individual. Or posting information about how to file a complaint or grievance, including an anonymous complaint in a public location and in a format that anyone can understand. Again, on this slide, here are the examples of where you might find the documentation at each setting, including the resident rights or resident handbook. When it comes to independent choices, the provider should offer individuals experiences based on personal interests, needs, or wants, which they can use to base future choices. Individuals should have a say in who has access to his or her personal possessions and living space. The provider should create a plan for the appropriate balance between autonomy and safety, and give the individual's personal preferences priority over a guardian or provider's preferences, unless for a documented health or safety reason. The rule states that the setting optimizes but does not regiment individual initiative, autonomy, and independence in making life choices, included but not limited to daily activities, physical environment, and with whom to interact. This could mean skipping a meal, declining to participate in events they are not interested in, or not wishing to be bothered after 10 p.m. Individuals get to make their own choices, even if they are bad ones. Some examples of best practices for independent choices include getting to know individuals and their interests and facilitating activities to match those interests, encouraging individuals to participate in activities of their choice that are consistent with the goals and objectives identified in their plan of service, including activities within the setting, as well as provider-organized activities in the community, and ensuring the physical setting supports a variety of individual goals and needs, such as having space for individuals to move about and accommodating individual and group activities. Here is the list of some examples of where you will find the documentation at the facility or site. But an important note is that you will probably gain most of your information from the observation and interviews with each individual. The next topic is choice of services and supports. You want to ensure individuals are provided a choice to use their own physician, pharmacy, and other practitioners and not be required to use the facility physician or pharmacy, etc. Often at admissions, many individuals sign an agreement that they will use the facility's medical team and don't even realize they signed it. It is really important that individuals are afforded the opportunity to continue to see their own provider in the community. This is a basic tenet of Medicaid policy. Individuals get to choose their own provider and where they wish to receive services, and that cannot be ignored. Some examples of best practices are allowing individuals opportunity to choose whether they want to receive services, being able to choose from available alternatives when appropriate. Case managers should be encouraging individuals to make their own choices whenever possible, but especially in relation to services and supports and who provides them. And staff taking time to understand fully what services or supports an individual would like to receive off-site and provide the support needed to ensure that that can happen when feasible. In summary, providers cannot require all services to be delivered by their chosen service providers at the setting. Individuals have to have the ability to go to their own practitioners in the community without any barriers inhibiting them. Again, here are some reminders of where you might be able to find this information. You may find reference in the individual handbook, through interviews, and the care plan as to whether or not an individual has chosen to see their own provider in the community. Next is community integration. While there is no rule requiring all activities have to be brought into the setting, individuals who receive home and community-based services must have equal access to the same community resources and activities as the greater community. Providers cannot restrict or obstruct community access. It is critical to ensure service and support delivery practices do not isolate individuals from the greater community. Providers must ensure service and support practices do not create an environment that is institutional in nature, and they must provide support for individuals and their desires to participate in the community. If an individual prefers to go into the community to a local craft show rather than a scenic bus ride, the setting must assist the individual in making that happen. Community integration can help individuals from feeling isolated and disconnected from the world outside of the assisted living. A great example of integration into the community based on individual preferences occurred at a setting where one of the new individuals at the setting was an avid bridge player. The individual spoke to the assisted living team and they assisted in setting up a bridge game for those who were interested from both the setting and the community. And when the game was not at the setting, the assisted living helped facilitate the transportation to the bridge game in the community for those who were interested. And here's the slide on the documentation examples for community integration, activity calendars, resident council meeting notes, the reviewer's observation, and interviews with resident staff is likely where you will find the bulk of the information. Now I'm going to turn the next part of the presentation over to Angela Baker.
Thanks, Erica. The first topic that I'm going to talk about is control of finances. We want to ensure that individuals have the freedom to control their personal funds and make the choice to manage it themselves or to manage it through the facility. If the individual plans to have the facility manage their personal funds, there are some expectations. The first is that the individual has control over their personal funds and that they have access to information about their account. And second is the provider identifies the roles and responsible parties related to that money management. And then third, the staff are trained to safeguard the funds and follow the individual's care plan when it comes to handling individual funds. Some examples of best practices related to control of money would be some of the following. The lease or residential agreement, or even the residence rights document, include an individual's right to control their own personal resources. Another example is allowing access to individuals' personal resources when they choose, and it isn't restricted by business like office hours. If this is something that you do see posted within the facility, make sure to always ask how the individuals would access their resources after hours. It's also important that the setting gives individuals account statements, that way that they can review any account activity and kind of reconcile it. And then when it comes to adult daycare, we know that adult daycares don't control personal finances, but it's always good to have an understanding of how they handle money when it comes to outings. Some adult daycares specialize in dementia care, and if an individual needs to have money for an outing, how does this setting handle that situation? This information can be found in many places. Some facilities spell it out in their lease or residential agreement, and depending on the individual's choice, there may be some additional papers that would need to be signed by the business office and the individual. The setting may also have a policy on controlling finances. Look around to see if there's anything posted where the individuals would go to withdraw their money from their account, and as far as the procedure of withdrawing those funds. This is also something that can be discussed in resident and staff interviews. The next topic is employment or volunteer opportunities. We want to make sure that providers engage with the individual along with their support team and are using person-centered thinking. We want to ensure that individuals' needs, desires, and their choice to work or volunteer is assessed, and that the individual can make that decision using informed choice. Individuals must have opportunities to seek and experience employment, which includes working in a competitive integrated setting if they desire. The provider should assist individuals who express an interest to work or volunteer in the community. Some clarification is that we do understand that many individuals choose not to work for various reasons. A provider must still ask if the individual has that desire to work and just not make assumptions. A residential provider must support an individual in working if desired, and they must work on removing any potential barriers and be flexible and accommodating to the individual's work schedule. On this slide are a few links, and the first one is to a news story about how volunteering can help make life more meaningful for senior citizens. It's a good example of the benefits that work and volunteering could have for individuals that want to pursue something in the community. The second link is a volunteer match database. This can be used to assist providers to find those volunteer opportunities that may be near them. As a provider, they could find a few opportunities and post them on a community bulletin board to help meet this requirement. And then finally, we list out some local organizations where there could be some volunteer opportunities. A lot of them are located within many of our PAA areas. They could be metropolitan libraries, Volunteers of America, hospice facilities, VA hospitals, local food pantries, or the County Humane Society. This is where some of this information could be found. It's different in every facility. And also note that this does apply to adult daycare. So please ensure that the adult day setting is offering the same type of service to the individuals that are attending. The next topic that we're going to discuss is the lease or residential agreement. So we want to ensure that every provider has a lease or other legally enforceable agreement in place. The individual's unit is a specific physical space that the individual can rent or occupy under this legally enforceable agreement. The individual must have at minimum the same responsibilities and protections from eviction that tenants have under the landlord-tenant law of that state, county, city, or other entity. And this requirement just ensures that individuals who live in a provider-owned or controlled residential setting have the same rights and protections as other community members living within the same setting. The lease or residential agreement should contain the HCBS required resident rights and should inform the individual and the provider of their responsibilities, such as the amount and the due date for both the room and board and the liability, The individual responsibilities like maintaining their unit and not engaging in activities that would disrupt or cause harm to other residents. The provider's time frame for giving an individual a notice of eviction, also known as the 30-day notice, and conditions under which the provider could terminate an involuntary termination of that lease or residential agreement, as well as the individual's appeal rights should the eviction process be started. And a provider must give a signed copy of that lease or residential agreement to the individual. And for adult day services, make sure we know that there's not a lease or residential agreement, but there may be something similar that is in accordance with 173-3902 B3E, and it has to follow these steps when it comes to ending the services as well. Moving right along, our next topic is lockable doors. So individuals residing in the setting must be able to lock their doors and come and go as they choose. This means from their room as well as the setting. Individuals on assisted living waiver must have the same rights as individuals who live in their private homes. This requirement ensures that individuals have privacy that they desire. The exception to this is when there's a modification in the care plan, which we're going to go into further detail when it comes to modifications later on in this presentation. Providers are responsible for ensuring the following: that individuals have a lockable bedroom door if it is a 2-bedroom shared unit, or a lockable front door of their unit. Individuals have control over their privacy and always have the option to lock their bedroom door or the unit door from inside as well as the outside, and as well as ensuring that they have their own key to that unit. If there are circumstances that would prevent an individual from having a locked bedroom door or unit door, like the modifications that we're going to talk about later, we want to make sure that there are discussions occurring during the person-centered planning process and that they are documented in the person-centered service plan with the PAA and the setting. We want to make sure that these conversations are happening between both, and that staff must respect an individual's privacy and that they can do this by knocking and then waiting to get that verbal permission before entering the unit. Just a few more things that providers are responsible for when it comes to lockable doors. We want to make sure that staff that are allowed to use that key or fob to enter the room, also what we call the master key, that it's determined by the provider and it must be communicated to all the individuals. That way the individuals are aware who would have access to their rooms, and sometimes they might be at designated times like housekeeping or laundry, and that staff will only access the individual's unit as needed to address any health or safety concerns, or like I said, during some of those prearranged times. There are examples of this requirement. So they are using standard locks on all bedroom and unit doors, and the individual has a choice to lock them when they choose. Knocking and receiving that verbal permission to enter the room just before opening the door and walking in. Allowing individuals who live within the setting to come and go as they choose, even if the front door of the facility is locked, and ensuring that they have a way to enter the building if it is locked, like maybe having their own key, key fob, or there's some kind of keypad that they can use to enter the building after hours. And then in the case of adult daycare, it's important to ensure that the shower room or the restroom doors are able to be locked to ensure privacy within the setting. These are some of the places that you can find the information that we've talked about when it comes to lockable doors, but just make sure that the paperwork, wherever you find it, spells out master key and the parameters as to who has access to that master key, where it's stored, do certain staff members have it on them during the shift, and then when it can be used. Ensure that the individuals are issued a key upon admission and that they know how to get it replaced if it's lost. And we also know that some individuals choose to never lock their unit doors and they choose to leave it open, which is their right to do so, but ensure that they do have that key should they choose to lock their door. The next topic is roommates. So we always want to make sure that individuals have a choice to have a roommate if they are already living in a shared unit. Things to consider is that individuals must request to share their unit. We want to make sure that individuals have that pre-existing relationship prior to the setting just putting two individuals together. We want to make sure that the staff consider roommate compatibility and must give each individual an opportunity to provide input on the decision. And that authorization of sharing a unit must be in the individual's person-centered service plan. And just note that two individuals who have never met should not be sharing a unit. We want to make sure that that existing relationship is already in place prior to them being put in the same unit together. These are all different areas of the paperwork where you could potentially find information about roommates, but we want to ensure that roommates is addressed in the documentation. And it might be good to just ask the administrator, whoever you're working with at the facility, if the setting even has any shared units. A lot of the settings are moving towards just private units. And if there are shared units, ask if they do have waiver individuals in them or not. And even if they don't have any shared units within the facility, it's always still good to go over with the facility the parameters around roommates, when they should be considered, about that existing relationship, things like that. Just that way they are aware. To keep the presentation going, our next topic is going to be furnishings and decorations. So providers must allow individuals' living space to feel like a home. So that entails being furnished and decorated as they choose within the boundaries of that lease or residential agreement. It's important for individuals that they must know when it comes to furnishing and decorations that they are able to bring their own furniture to the setting, like their favorite chair or their own comfortable bed, have their own personal items displayed, like maybe their favorite sports memorabilia or their family photos, and that their unit must reflect their own personal sense of style through the use of colors, decorations, and art. And then it's also important to note that in the adult day setting, decorations and furnishings must meet the needs of all that attend that setting. It's important when you're looking through the documentation, trying to find information about furnishings and decorations, that somewhere within the documentation you find something that goes over the parameters of what they are and possibly aren't able to bring into the setting. You may see that there are some restrictions, like no nails in the wall. They might request that they use command strips, which a lot of times can be furnished by the facility, or they may have a parameter around that they want a maintenance man to be the one that hangs anything on the wall. So you might see certain things like that, which is fine as long as they're just not telling them flat out no, they can't hang anything on the wall. The last topic that I'm going to be reviewing is daily schedule. So we want to make sure that providers ensure that individuals have control over their day-to-day lives in the same way as somebody that lives in the community. This can entail that individuals have control over when they would like to get up, get ready, and their choice in food. That they have control over their schedule and activities. Examples are when they bathe, exercise, or just when they choose to participate or not participate in activities. And that activities are flexible and work around individuals' preferred schedule within the setting. And another important thing to note when it comes to this is that they have access to food at any time. This means meals and snacks. And that there's a place to store their snacks, like within their bedroom or if they have their own kitchen. And this even counts at adult day centers. We want to note that vending machines don't meet this requirement and the setting must provide snacks. Some different things that we want to consider would be if individuals have the choice of when, where, and with whom that they would like to eat. Individuals can eat a meal or snack at any time. Even if they choose to miss a meal, we want to make sure that they're not having to wait around for their next meal to eat. And that the provider can set aside a plate for them or reheat it later, or provide them with an alternate meal. That way, when they return, if they're out of the setting, for a doctor's appointment or other various reasons, visiting with family, running errands, and that individuals have the right to refuse to participate in activities. These examples apply to both assisted living and adult day service, so we want to make sure that they're happening in both. These, once again, are the documents that you can review to try to find information about daily schedules. One thing to pay attention to in your observation is dining room assignments. We understand that some individuals prefer to have assigned seats, but we want to make sure that the individuals have a choice and that it isn't the setting making that decision for them. Well, that wraps up my portion of the presentation, so I'm going to turn it over to Heather to wrap us up.
Visitors. Individuals have the right to have visitors at any time. So what does this look like? Individuals should have the opportunity to create close, private, and personal relationships without any unnecessary barriers imposed on them. Individuals should be able to have visitors at any time without any type of restriction, and providers should not be screening the individual's visitors. The expectation is that individuals may have a choice of their visitors with no restrictions on visit times. The expectation is that they may have overnight guests. Please note that for certain settings, the lease may specify that visitors that stay longer than a certain number of days must be put on the lease. This is a standard policy and is still HCBS compliant unless it is more restrictive than standard lease language. The expectation that individuals may also have access to unrestricted visitor areas and the right to privacy during visits. This also applies to adult day services as well. There could be times where family or friends want to visit an individual at an ADS or to leave the ADS to spend time with family. Ensure that visitors are allowed at the setting and that there is a space for an individual to visit in private. And here are examples where visitor documentation can be reviewed. Examples: the lease residential agreement, resident rights, the handbook, policies, best practices, staff training, observations, and most specifically, resident interviews and staff interviews would be appropriate here. Physical accessibility. The setting is physically accessible to the individual. Providers must ensure that an individual's physical environment meets his or her needs. Individuals must have the right to move about the setting and not be confined to one defined area. They should have unobstructed access to all areas of the common living space that they wish to access. An individual should not have to wait for access to the building. If they are out after hours, an entry door is locked. And here are some best practices and examples of physical accessibility. 1. Having a conversation with an individual about their accessibility needs upon move-in. 2. Ensuring the physical environment meets the needs of individuals who live in the setting, such as individuals can use common areas in the home, like the kitchen, the dining area, laundry, and shared living areas to the extent that they desire. 3. Notifying individuals that they may request a reasonable accommodation and the provider has a process in place to make that request. And finally, providing individuals with a key, a fob, or a code to gain entry after hours when the doors are locked. Where to find documentation to review for physical accessibility. Again, as we have stated previously, you can find information for this, particularly with resident interviews, with the observations, within the resident handbook, the lease agreement, and within policies. Modifications. A modification is an agreed upon restriction which is implemented by the provider to limit an individual's rights in order to address an identified need or risk to their health and safety. The PAA staff have several responsibilities to review in terms of modification. 1. Review the provider's process for initiating a modification when a significant change occurs. 2. Ensure modifications are documented in the individual's charts. 3. Review how modifications are communicated to provider staff and how they are implemented. 4. Review how modifications are communicated to the case manager assigned to that particular individual. 5. Review how the provider ensures that modifications in place match what the case manager has in place on the PAA care plan. And lastly, review how often modifications are reviewed. A rights modification cannot restrict all individuals in the provider's care just because one individual in the setting needs to have that restriction put in place. Rights modification should apply only to the individual with the need or living with the modification. The provider also has responsibilities for modifications. They need to participate in the person-centered service plan development process. They need to ensure that any modification to the settings requirements are authorized through that person-centered service plan. Ensure that all modifications are implemented in the least restrictive manner that is necessary to protect the individual. and they need to provide support to reduce or eliminate the need for the modification in the most integrated setting in the most inclusive manner. Providers need to also complete ongoing assessment and evaluation of that modification to ensure it does remain appropriate to meet the needs of the individual. The provider needs to collaborate with the individual and their case manager when any adjustment to the service plan may be needed, and ensure that the service plan matches what the case manager has in place within their care plan. Here are some modification examples. The first, protections from eviction. The lease may say you cannot remodel. However, an individual in a wheelchair may wish to have a lower counter. The case manager would need to work with the property owner to make that modification, and there may be language added that the property must be restored to its original condition. Secondly, privacy in their sleeping unit. An individual had a recent inpatient mental health hospitalization and is currently on suicide watch, with staff checking in on that individual every 15 minutes. Another would be sharing units. An individual has an established relationship with another individual that would like to share a unit, but was given a private unit by the setting upon admission. Furnish and decorate their living unit. Individual may have a history of hoarding and bedbug infestation, so limitations on outside furniture may be put in place. And lastly, visitors. Perhaps an individual's nephew has financially exploited them in the past and is now not permitted in this facility. Here are some additional modification examples. This would be a requirement to modify that individuals have access to food at any time. In this scenario, Sean has Prader-Willi syndrome, which is a condition that causes him to ingest large quantities of food. He and his doctor are working together to manage that condition. In the meantime, Sean and his guardian have worked with the care coordinator and provider to determine that limiting his access to food items will help him remain healthy. Sean's shared living services provider will help him build the skill set to work toward the ability to manage his food intake independently. In this example, we look at units having lockable entrance doors. Lucas is diagnosed with severe depression and he has exhibited self-harming behaviors. He, his provider, his care coordinator, and his person-centered team have agreed that having a lock on his bedroom door will put him at higher risk for serious injury or death if he self-harms, and a staff person is not then able to reach him immediately. Lucas, along with his team, have determined that the provider will temporarily remove the lock from his door, and they will implement a regular 3-month schedule of staff checks. Lucas and his psychiatrist will work to identify a balance of medications that fits his needs. He and his support team will revisit the issue in 3 months to then determine if staff checks need to continue and if at that time the lock can be put back on. Some examples of where you can find documentation in regard to modifications. Of course, as we've mentioned before, you're able to see these type of things in the lease agreement with observations, resident interviews, staff interviews, policies. In the facility and the PAA care plans, of course, they should be both matching. And best practices, find out how the setting implements those modifications, how they communicate it to the case manager, and how they make sure the care plan matches the case manager care plan. And how often are these modifications being reviewed to determine if they are still necessary. So now we're going to look at a settings category example and discuss why it is categorized the way that it is. In this example, we're looking at the provider Whetstone Gardens and Care Center, and you will see in this photo on the left with the red tinted roof is the skilled nursing side, and on the right with the gray tinted roof, that is the assisted living side. So the reason we're discussing this provider is that this setting was originally categorized as a category C because the assisted living was attached and co-located in a nursing facility. But upon further review by ODA, it was determined the setting was actually a category B, and here are the reasons why. The assisted living facility is totally separate from the nursing side. There's a long hallway separating the two settings from each other, which includes a row of administrative offices. Looking at the Google map, you can see where the two buildings do connect. Also, looking at the floor plan, ODA saw the assisted living rooms are actually only 2 wings, and the other wing is a kitchen, dining room, storage room, etc. The second floor still connects with the nursing side, but again, there's a hallway lined with administrative offices, which does separate the assisted living from the nursing side. Finally, the third floor is only assisted living units, and it does not connect to the nursing facility. Another reason this was moved to a category B is because the addresses of the two facilities are actually different. The assisted living side is number 3700, and the skilled nursing side is number 3710. Additionally, the assisted living main entrance is separate and distinct from the nursing facility. Having separate addresses and a distinct entrance is another way that the assisted living facility was able to distinguish itself from the nursing facility. And finally, the assisted living staff are totally separate from the nursing facility staff. So this means that the aides and nurses only work for the assisted living setting. It is possible a nursing facility staff member might cover a shift on the AL side, but the staffing is not shared between the two settings. Okay, so recapping why this provider, Whetstone Garden Care Center, was moved to a Category B from a Category C. So as I just mentioned, the AL setting is in a separate building from the nursing facility. The AL setting has a separate address from nursing. The AL setting has separate staff, and the AL setting and nursing facility have separate operating budgets. So now we're going to look at a few settings category examples and think about if it would be categorized as a B or a C. So in this first example, here's a scenario. The setting does not isolate individuals from the broader community. No noted evidence of physical, chemical, or isolation techniques are found. There are no cameras. There are no barriers. The setting is not co-located in the same building as a publicly or privately operated facility that provides inpatient institutional care. So would this be a Category B or a Category C? The answer is a Category B. And in our next example, here is the scenario. This setting has an assisted living facility, which is co-located with a private or public institution. The two facilities do share the executive director, director of nursing, and nursing staff, and the two facilities do have separate entrances and signage. So would this be a Category B or a Category C? The answer is a Category C. The staff can be shared, but they must demonstrate that they are not providing the same institutional care to the assisted living individuals. And the two separate entrances and signage do provide meaningful distinction between the assisted living and nursing facility. Okay, so next we're looking at meaningful physical distinction. So the setting needs to demonstrate a physical distinction between the HCBS setting and the institutional setting. And this should really include, at a minimum, separate entrances, separate signage. All maps should clearly show the HCBS facility in relation to the institutional setting. There should be physical divisions, differences in décor. And you can see all of this in Rule 5160-4401B1. So now we're looking at meaningful operational distinction. So the setting needs to demonstrate an operational distinction between the HCBS setting and the institutional setting. So what would this look like? You want to look at the corporate structure, if that's applicable. Are the finances separated between the nursing facility and HCBS setting? For example, the nursing facility and HCBS setting have separate accounts. Are staff shared between the nursing side and the HCBS setting? For example, if staff are shared between the two, can the HCBS setting ensure there is separate training? Is the director of nursing, administrator, social worker, or activity staff shared between the nursing and HCBS setting? So it is also about the individual's experience, and it must be distinctive from the individuals in the nursing facility. Ensure that the setting isn't running both the nursing facility and the HCBS setting the same, and that they are actually separate. So lastly, we want to discuss suggestions for how to prepare for an effective review. So what to review prior to the in-person visit. Look at the previous HCBS reviews, look at the previous SCR, look at the disciplinary history for prior HCBS violations, look at the care plans of individuals who are residing there prior to going on site, and the interview questions. Ensure you have a conversation with the individual. Send the HCBS checklist to the provider prior to the in-person visit and conduct a desk review on as much of the documentation as possible, and make sure to complete the onsite by day 365. Thank you for listening. This concludes our training on HCBS settings. If anyone has questions, please reach out to the provider oversight team. Thank you.